Welcome to the deep dive. Today, we're getting into a really common decision point for spine surgeons, cervical myelopathy,
Yeah.
specifically that choice between a ventral or a dorsal approach.
It's a big one. And understanding the nuances, the risks and benefits of each is just crucial.
Absolutely. So, we've gathered quite a bit of research here, meta-analyses, RCTs, cohort studies, the works basically trying to cut through the noise.
Yeah, trying to synthesize it.
Exactly. Our mission really is to pull out the key takeaways from the literature to help you, our listeners, refine your strategies for managing these patients.
Sounds good. There's a lot out there, so focusing on the evidence is key. Where should we start? The anterior approaches.
Yeah, let's kick off with the anterior ventral side of things. So we're talking ACDF, ACCF, corpectomy. What does the research say are the main upsides here?
Okay, well, looking at some high-level evidence, there's a 2025 pooled analysis
Mm.
at Gettle in Spine Journal. It looked at individual patient data, quite powerful stuff, and it showed a greater improvement in SF36 PCS and NDI scores at the one-year mark with anterior ventral surgery. This was particularly noticeable in patients who had mild DCM to begin with.
Interesting. So a potentially bigger early bump in function and disability scores for those milder cases?
Seems that way, yeah. An early quality of life benefit.
Okay. What else supports going anterior?
There's also a meta-analysis from 2015, Sun et al., in clinical neurology and neurosurgery. This one focused on multi-level CSM
Mm-hmm.
and indicated that anterior approaches were linked to higher postoperative JOA scores, so better neurological function, and also shorter hospital stays.
Shorter stays, always good to hear. What about alignment, kyphosis correction?
That's often a key driver for anterior. A narrative review back in 2007, Wiggins and Shaffrey in neurosurgery really highlighted this. They noted anterior is often preferred for, rigid kyphosis.
These you can get right at it.
Exactly. The direct access lets you do more thorough decompression and, crucially, get better lordotic realignment. That's so important for the long term.
Makes sense biomechanically, yeah. Go straight at the problem. Are there studies comparing different types of anterior surgery?
Yes. There's a 2009 retrospective cohort in Spine et al. They looked at two-level ACDF versus one-level ACCF.
Okay.
Found pretty similar clinical outcomes overall, but the ACDF group had shorter operative times, less bleeding, and actually maintained lordosis better.
So for straightforward two-level cases, maybe ATDF has some technical edges, less time, less blood loss, better curve.
Potentially, yeah, in the right patients.
And what about specific things like OPLL, ossification of the posterior longitudinal ligament?
Good question. A recent meta-analysis, 2024 in Annals of Medicine and Surgery by he and colleagues, suggests anterior is actually more effective for OPLL, specifically when conservative measures haven't worked.
Right, directly tackling that ventral bone formation.
Precisely. You're decompressing the cord directly from the front where the OPL is.
Okay, so it feels like there's a strong case for anterior in several situations. Milder DCM, maybe for early quality of life. Multi-level CSM, definitely kyphosis correction, maybe OPLL.
Yeah, quite a few indications seem to favor it based on these studies.
But it's surgery. There are always risks. What are the major drawbacks or complications we see highlighted for anterior approaches?
Right, and this is where the balance comes in. Several big studies flag higher complication risks.
Mm-hmm.
A key one is a 2021 RCT in JAMA.
Okay, high impact.
Definitely. It
Yeah.
reported a significantly higher complication rate in the ventral group, something like 48% versus 24% in the dorsal group. And dysphagia, difficulty swallowing, was a really notable issue.
Yeah, dysphagia is a big one post-op. Really impacts recovery. Is that a consistent finding?
It seems to be. Another RCT, this one in Journal of Neurosurgery, Spine from 2020 by L. Gandour et al., also found longer operative times, and again, higher rates of dysphagia with the anterior approach. And add to that a 2023 meta-analysis in the European Spine Journal by Zhu et al. They found more overall post-op complications anteriorly too. Though interestingly, they did note less intraoperative bleeding with anterior.
Huh. So maybe less bleeding during the case itself, but higher chance of other issues popping up afterwards, especially swallowing problems.
That seems to be the pattern emerging from these studies, yes.
Any other specific complications that stand out? C5 palsy.
C5 palsy is always a concern. A 2013 systematic review in Spine by Shamji et al. Did mention a potentially higher incidence with more extensive anterior work like corpectomies or hybrid approaches compared to just multiple discectomies.
So the more bone you take anteriorly, the higher that potential C5 risk.
It's a possibility raised in that review, yeah. Needs careful consideration.
What else?
Well, a 2016 meta-analysis by Ma et al. Also just generally pointed to a higher overall complication rate with anterior approaches. And another retrospective cohort, 2023, in Journal of Clinical Medicine by Zhu et al., reported longer op times anteriorly and mentioned issues like hematoma and, yep, dysphagia again.
Okay, so the signal seems pretty consistent. Anterior approaches, while offering significant benefits for alignment and maybe neurological outcomes in certain groups, carry this higher risk profile for overall complications, especially dysphagia, potentially C5 palsy with bigger resections, and often take longer in the OR.
That's a fair summary of the potential downsides based on this evidence.
All right, let's pivot then. Let's talk about the posterior dorsal approaches, laminectomy, laminoplasty, maybe with fusion. What are the key advantages highlighted here?
A big one, often cited, is suitability for multi-level stenosis. That same 2007 neurosurgery review by Wiggins and Shaffrey we mentioned earlier, they recommend posterior for this reason.
Makes sense. You can open up the whole canal from the back more easily if it's pinched at many levels.
It's exactly. Facilitates doing consecutive laminectomies or a long laminoplasty.
Any other advantages?
Interestingly, remember that 2015 meta-analysis by Sun et al. While it favored anterior for general multi-level CSM outcomes, it did find shorter operation times and higher neurological recovery rates, specifically in OPLL patients treated posteriorly.
Oh, that's interesting. A bit counterintuitive maybe, but suggests for OPLL, posterior might sometimes be more efficient and yield good results.
The finding worth noting, yeah.
Yeah.
It might depend on the specific morphology of the OPLL.
Okay. What about preserving neck motion?
That's another potential plus for posterior. A 2023 retrospective cohort in the European Spine Journal, the same Zhu et al. Study indicated posterior approaches were associated with a greater range of motion afterwards compared to anterior fusion.
And preserving motion is often a big goal if possible.
Absolutely. Patients value that.
What about overall complication rates and surgical time generally?
Well, that same 2023 Zhu study actually reported fewer overall post-op complications with the posterior approach, contrasting with some anterior findings. And the 2023 Zhu et al. Retrospective cohort backed up the finding of shorter operative times posteriorly.
Okay, so potentially quicker surgery, maybe fewer complications overall according to some studies, and better motion preservation. Anything new on the posterior technique front?
There's work on less invasive options. A 2022 retrospective cohort in operative neurosurgery by Schaller et al. Looked at unilateral posterior approaches.
Just going in from one side.
Yeah. And they found it could achieve sufficient decompression with comparable long-term results, at least for primarily dorsal compression, so potentially less disruptive.
Interesting. Less invasive options are always welcome. Okay, but just like the anterior approach, posterior isn't without its risks. What are the documented drawbacks here?
Right. The classic concerns with laminectomy alone, highlighted again in that 2007 neurosurgery review, include things like late neurological decline, the development of kyphosis over time, instability, and sometimes postoperative radiculopathy.
Those are the big ones that often push towards adding fusion posteriorly, right, to prevent that late instability and kyphosis.
Precisely. Fusion helps mitigate those specific risks of decompression alone. Another issue is persistent axial symptoms, neck pain. A 2020 retrospective cohort in the Chinese Medical Journal noted this can be a real concern after posterior surgery.
Fixing the myelopathy but leaving the patient with significant neck pain is obviously not ideal.
Definitely not. It's a trade-off you have to discuss.
What about C5 palsy from the back? We talked about it anteriorly.
The picture's a bit muddy, honestly. That 2016 meta-analysis by Mom suggested a trend towards lower C5 rates with posterior surgery, but then a 2014 systematic review by Verheiden indicated a trend towards higher rates.
So the jury's still out on C5 palsy risk comparing the two. No clear winner.
Based on that conflicting evidence, it's hard to say definitively. It likely depends on technique, patient factors, maybe extent of decompression.
Okay. What other specific posterior complications pop up in the literature?
Wound infections and pseudoarthrosis failure of fusion. The 2025 pooled analysis by Bank et al. Reported a higher likelihood of both of these after posterior surgery.
Infection and non-union.
Yes.
Those are major issues requiring potential reoperation.
Absolutely serious complications. And supporting that, a 2016 retrospective cohort in World Neurosurgery by Harrell et al. Found significantly greater total and deep wound infection rates and also a higher overall complication rate, with posterior dorsal approaches compared to anterior in their series.
Wow. So that study directly contrasts with the Zhu study suggesting fewer posterior complications. Infection risk seems like a recurring theme posteriorly in some datasets.
It does seem to be more prominent signal in some of the posterior literature, yeah.
Anything else?
Just to round it out, that 2023 retrospective by Zhu et al. Also mentioned instances of axial pain and C5 palsy occurring in their posterior group as well.
Okay, so summing up the posterior side. Good for multi-level disease, maybe efficient for some OPLL cases, potential for shorter surgery, better motion preservation, but risks include late instability or kyphosis if you don't fuse, persistent neck pain, and a concerning signal in several studies for higher rates of wound infection and possibly pseudoarthrosis. And the C5 risk is still debatable.
That captures the posterior landscape pretty well. It's definitely a distinct risk-benefit profile compared to anterior.
Which really brings us to the core comparison, doesn't it? Weighing these different complication profiles, the successes, the failures.
Exactly. It's clear both can work, but the potential pitfalls are different. Anterior seems to lean towards dysphagia and maybe C5 palsy in extensive cases.
While posterior seems to carry that higher wound infection burden, potential instability without fusion and axial pain.
Right. But what's fascinating is that despite these different complication patterns, several studies show quite comparable neurological outcomes.
Really? So even if the side effects differ, the main goal, improving the myopathy, might be achieved equally well.
In many cases, yes. That 2020 Chinese Medical Journal study suggested it. And importantly, the big 2021 JAMO RCT by Feelings and their AO spine group found similar neurological recovery between ventral and dorsal groups at 2 years.
That's a huge point. It shifts the focus, perhaps, from arguing about which one is better overall neurologically to which specific risk profile is more acceptable for a given patient.
Precisely. It all comes back to patient selection. This is emphasized again and again in the literature. You look at narrative reviews in neurosurgery, Acta Neurochirurgica, HSS Journal, meta-analyses like one in clinical spine surgery, they all say the same thing.
You have to consider the details.
You absolutely have to. How many levels? Where is the compression truly ventral, or more circumferential, or dorsal? What's the sagittal alignment like? Does the patient have significant kyphosis? What are their comorbidities? It's about matching the approach to the specific problem.
And sometimes, for the really complex cases, maybe it's not an either situation.
Correct. For very extensive multi-level disease, especially with significant deformity or instability, a combined anterior-posterior approach might be the necessary strategy. That's discussed in reviews in places like Acta Neurochirurgica and the Journal of Clinical Neuroscience. It's a bigger operation, obviously, but sometimes required.
And we shouldn't forget the patient's starting point influences things too, right? How bad were their symptoms beforehand?
Definitely. Preoperative severity, and also the duration of symptoms, how long they've had myelopathy, consistently show up as predictors of outcome. Studies in the Indian Journal of Orthopedics, Clinical Orthopedics, and Related Research mention this. It underscores the potential benefit of intervening before the deficits become too severe or long-standing.
So it really boils down to needing a very personalized strategy for each patient.
Couldn't say it better. It's not a cookbook. It requires careful assessment of the patient, the imaging, the goals, and matching that with the known pros and cons of each approach, and frankly, the surgeon's own experience and comfort level.
Okay, so after digging through all this evidence, what are the absolute key messages for spine surgeons wrestling with this ventral versus dorsal decision in cervical myelopathy?
I think the first is that both approaches do work. They are effective tools, but they come with different baggage, different risk profiles.
Right.
Anterior often shines for direct ventral decompression, fixing kyphosis, maybe giving good early neurological recovery, but you have to watch out for dysphagia, maybe C5 palsy, and potentially longer OR times.
And posterior.
Posterior is great for accessing multiple levels, might be quicker, maybe better motion preservation without fusion, but you've got risks of late instability or kyphosis if unfused. Axial pain is a concern, and that signal for wound infections and pseudoarthrosis seems real in some studies. C5 risk is still a question mark comparatively.
And the absolute critical factor is tailoring that choice.
Absolutely. Meticulous evaluation. Levels, location of compression, sagittal balance, patient health, symptom duration. It's all part of the equation. The best approach isn't universal. It's specific to that individual sitting in front of you.
That's a really vital takeaway. It leaves us with maybe one final thought to ponder. As we get better imaging, better minimally invasive tools, a deeper understanding of biomechanics, how might these advances change this decision-making process in the future? Could we see even more nuanced, perhaps hybrid or staged approaches becoming more common to minimize the downsides of both?
That's the exciting part, isn't it? It's constantly evolving. Minimally invasive techniques, robotics, navigation, biologics, they all have the potential to refine how we tackle this, potentially making surgery safer and even more tailored. It'll be interesting to see where the field goes.
Definitely something to keep watching. Well, thank you for walking us through that complex landscape. That brings us to the end of this deep dive.